Boston Medical Center. And you may be shocked to know, when I was talking to the EMS crews here, I was trying to figure out where I might be shooting overdoses, and I spoke to them in, I think, August. And so far in 2017, they'd already responded to 3,000 overdoses, just between January and August.
Just in Boston?
Just in Boston.
Wow.
In Vancouver, they responded to 6,000 overdoses just on the downtown east side last year. That's a 10 square block radius.
So in terms of harm reduction in the US, there is a scene in the film with Dr. Gupta in West Virginia, and do you want to describe the kinds of things he was doing in West Virginia?
So one of the scenes, we go out with Dr. Gupta in West Virginia to try to distribute free needles, because West Virginia is also ground zero, not just for the opioid overdose death rate, but for Hep C and HIV. They're worried about a new outbreak. And so they were trying to go to McDowell County, which has an overdose death rate 7 times the national average, and do Hep C testing, HIV testing, and provide needles, provide Narcan. But these programs are being shut down. Like Charleston just shut down its needle exchange program. I think Orange County, I was just reading today, shut down a needle exchange program. You'd think we know steps that save lives, save money, keep people safe, stop the spread of disease. What's the reaction? Let's not do it. That's the reaction in this country.
Okay, I want to talk about medication-assisted treatment in a little bit, but first I want to talk to Peter and Emily a little bit. So, Peter, I understand that you work with a digital pill. Can you describe what a digital pill is and what does it do?
Sure. So, part of our research, we look at the opioid epidemic from, I think, a lot of different lenses. And one of the things that we don't really talk about is that there's this whole world of exposure to opioids, right? So an exposure to even one dose of an opioid puts someone at risk of long-term non-medical use at 1 year. So one of our questions as researchers is, there's this huge influx of opioids, but how do we prevent exposure, and how do we safely treat people? Because I mean, the answer to the epidemic is not to stop prescribing opioids, right? Because we're gonna have pain and we need to treat it. It's about how do we do it safely? And one of these technologies that we've used is a digital pill. So it's a gelatin capsule that we printed a radio frequency circuit on, and we compounded it with oxycodone. And in emergency department patients who have acute pain who need opioids, we can dispense a digitized oxycodone pill. And when people ingest them, their stomach acid, the chloride ions, essentially act as a battery and power this radio frequency circuit. So you get a radio signal every time someone takes one of these medications. And when you think about that, the power there is that we can detect how people are using medications, especially opioids. And the big problem with opioids is that, as physicians, these are probably one of the most powerful medications that we have, right? Because they treat pain, but they also cause an epidemic of addiction. Yet, this is one of the only medications where the onus of dosing is not on the physician, it's on the patient, right? We tell you, take your medication as you see you need it, but we don't do that with chemotherapeutics, with antibiotics, it's just with opioids. So this is a technology in which we're hoping that we can detect how people use opioids, and we can detect dangerous patterns of use. So potentially escalation of opioid use, that may be an indication that tolerance has set on. And wouldn't it be great that if we can use these technologies to detect this, we can push forward the interventions and the behavioral science that we know works to help treat opioid addiction. Let's try to prevent that from happening using these kinds of technologies.
So does the pill actually sit in your stomach and stay there, or nothing stays?
Sure.
What happens to the pill?
So it's a gelatin, so it degrades in your body. And then the radio frequency transmitter, it's about the size of a sesame seed, and it's made of a silver alloy, which everybody has a little bit of daily kind of ingestion of that stuff, and it just passes in your stool. So every pill is tagged.
So you have to keep taking them.
Well, I mean, you don't have to keep taking opioids, but you take them, we can detect the change in patterns.
So I'm trying to think of the practical uses.
Sure.
So if someone is maybe supposed to take opioids for a week or 2 weeks, is that the kind of thing that?
Yeah, I'll give you an example. So we have a study where we are enrolling patients who have had spinal fusion surgery. So it's one of the more painful surgeries. And these people are technically, some people will go home with opioids for up to a month. And the question is, what do people really need that much? You know, and how long do you actually have pain after surgery? So by using this technology, we can look at the pattern of use, and we find that people do tend to taper off opioids at some point, probably a lot earlier than we as physicians think they do. But then there's also a group of people who, you know, have the opioids and they start to increase their use. And now, is that a medical problem where there's a failure in the surgery and there's an infection or pain that we need to address, or is that the onset of tolerance? So this gives us a point in which, you know, normally we would wait until a month to see the patient, but now when we detect a change in pattern, that triggers the clinicians to kind of talk to these patients at that time and say, you know, what's going on, and, you know, why has opioid use started to increase?
So do you see this as primarily a research tool, or do you see this as having a regular place in the policy of prescription opioids or other drugs?
I see it as both. So from a research perspective, I think it's helpful in helping clinicians develop guidelines for, you know, what is an appropriate dose of opioid for a specific condition? You know, how much do we need to give, and more importantly, what kind of anticipatory guidance can we give patients? So, you know, if you broke your ankle and you're on opioids, you know, can we tell you what the expected pattern of pain medication use is? On the other side, you know, if we have kind of some psychosocial screening that we do in patients that can help us kind of predict a semblance of who may be, I guess, at higher risk of developing opioid addiction. And I think in those patients, that's where the technology has real power, because we know you're at high risk, but at the same time, we still want to treat the pain. So can we do it safely and do it without preventing someone from developing tolerance?
I also wondered whether it could play any role with medication-assisted treatment if there's an issue with making sure that people are following their prescription
so
for that.
adherence to buprenorphine is a very big problem. Happily in the United States, buprenorphine abuse is not as
Which is Suboxone, which is talked about in the
So
film.
Suboxone abuse. So Suboxone is abused in Europe, for example. They're more common drug of abuse. Whereas here in the U.S., oxycodone and these other opioids are more powerful. But the ability to detect adherence to these things in the context of medication adherence is important too.
Yeah. About medication-assisted treatment, Sarah. So some critics say, oh, it's just replacing one addiction for another addiction. It's still addiction. So what did your experts say about that?
Well, the definition of addiction is the compulsive consumption of a drug despite negative consequences. And when you get on Suboxone or methadone and you start going to work and re-engaging with your family or going back to school, you no longer meet the definition of addiction. So just because you're dependent on a substance doesn't mean that you're addicted to it. And I mean, one of the reasons why I really wanted to feature it in the film is that it's really been a game changer, making opioid addiction, ironically, one of the most easily treated addictions now. It's giving people back their lives, and there's such stigma against it. Massachusetts is like leading the way, but in many parts of the country, I mean, you can't find it. And it's like, it would be crazy when they took Marie off the methadone. She goes into acute opioid withdrawal. She relapses, and then she loses her children. I mean, that's tragic, mismanaged, medicated assisted treatment programs.
And as some of the people you interviewed said, we don't talk about diabetics who are on insulin as being addicted to insulin.
Right, we don't. I mean, the whole language towards people with addiction is, the stigma is, we don't say if someone has a high blood sugar that they're sugar abusers. And yet we continually stigmatize people with addiction. We make it really hard for them to get treatment, and especially treatments that work. There's a lot of ineffective treatment in this country.
So for people who are in recovery, let's talk. Hey, Charlie. So Emily, what is Hey, Charlie? And how did you come to develop it?
So Hey Charlie is a mobile technology that we've developed that really helps people with social rebuilding when they're in recovery. So backstory to Hey Charlie. Charlie is my brother, and he has been in and out of recovery for heroin addiction for over 8 years now. And it was kind of said explicitly in the film that when you go to the emergency room and you overdose, they give you Narcan and then they send you back out. And we don't actually treat this as a chronic illness that has a lifelong process of recovery that needs to be supported. And when I'm very close with my brother, and I was watching these cycles of relapse, recover, and there was this thing that I always saw that was relatively untouchable by the healthcare system, and that was that he would be in recovery and, you know, seemingly doing great, and the wrong person would drive up the driveway to give him a ride. The wrong person would start texting him and calling him, and it was like to a T. You could predict he was going to relapse, and he would every single time. And I really started thinking about this, like, is this something that we can do something about? Maybe doctors can't prescribe a pill to make you change who your friends are, but can we use technology maybe to help people regain the autonomy to make better choices about how they interact with their environment? And so we developed Hey Charlie as a technology that just runs passively in the background of somebody's phone. And we have the ability to kind of determine the riskiness of things in your environment. So how risky are the people you're talking to? How positive are they? How risky are the places you're going? How positive are they? And when you're engaging in things that aren't good for your recovery, you know, we're not going to call the police, we're not going to tell your parents, but we're going to give you a tiny little nudge that says, is this a good idea right now? Are you sure you want to do this? And every single time we'll just keep nudging you and give you alternative strategies. And our philosophy really is that if you only listen to 5% of those nudges on day one, maybe on day two you'll listen to 10%. And eventually the number of triggers that are in the world that you are living in will go down. And so we're really focused on kind of capturing that environmental, social data to give people back that autonomy in this lifelong recovery process, and then also try to learn what we can kind of from that data to give back to the treatment providers and policymakers to tell them how they can better like restructure social and environmental components of recovery.
So I'm really curious about what your strategy is, because your app really depends on people informing the app of what are their biggest vulnerabilities. You know, what are the things that could make them relapse, and how do you get that information out of them, again, without stigmatizing the situation?
Right. So our kind of whole philosophy is that we're a friend on your shoulder. So we are acutely aware of how stigmatizing addiction can be. And so when you onboard with Hey Charlie, we ask you some questions about people that you frequently communicate with through your phone, places you frequently travel, and we don't ask you stigmatizing questions about them. We ask you very objective questions that come from behavioral science research. So there's a tremendous amount of research that shows that there are specific aspects of relationships that contribute to staying in recovery. So if your closest relationship is somebody who doesn't add stress to your life, is someone who tells you, I know you can do this, I know it's hard, you're actually going to have a much different outcome than if your closest relationship is someone who stresses you out. And so we have kind of devised a way using machine learning to understand from the answers to these questions just how risky someone is. We also actually do offer people the ability to say up front, I know this person's bad for me, or I know this place is bad for me. And in the clinical pilots we've done, it's actually been very surprising. Over 70% of people that we've worked with have been very upfront. I know this person's bad for me. And I think that's a really big misconception too about addiction, is this idea that people don't want to get better and that people don't know what their own challenges are. Most people are begging for something that will help them and for someone who will listen and believe that they are capable of making some of their own choices.
So where are you right now with the app? Is it available to everybody, or?
Yeah, so the app is free for download on the Google Play Store. We're only in Android right now, and we are doing some larger clinical pilots in Boston as well as in New York, where we start to kind of look at the population level data that we can collect and inform the organizations that we're piloting with, how to utilize their recovery coaches better and their peer supports and things like that.
I think it's really interesting that this touches on this, this notion of community and personal relationships. We're Nova, we're a science show, and we wanted to focus on the science. But Sarah, do you want to speak a little bit about just your experience and what you've seen, across the country in terms of what recovery means and what's necessary for people to recover is it just the Suboxone alone?
No. I mean, I think that what the Suboxone does for people with opioid use disorder is it takes away the cravings. So they're out of that horrible cycle of craving, using, crashing, binging. It normalizes their dopamine levels. But after that, it's really important to have good therapy, good community. I mean, people with addiction are shunned, and what we really need to be doing is enveloping them with support. And of course, the memories of using are so powerful. You never forget addictive behavior. They're some of the most powerful experiences you can have. And what's interesting about your app is a lot of people will say to me that, you know, a trigger came into their brain. They had no idea where it came from, and they'd be overwhelmed with cravings. So when you're on something like Suboxone, it seems to stop those cravings. But people eventually go off Suboxone once they get their lives back, once they're doing better, you know. So it's really important. I think it's an interesting app because, you know, just like with obesity, when you lose weight, it's about lifestyle choices. You've got to change your life to stay in recovery.
One thing that I think applies to both of you in these kinds of technologies, when I hear about an app where I've basically revealed all my weaknesses, how do you make sure that that's very personal and also kind of dangerous information? How do you make sure that that's secure and that it's not going to get out? And same, Peter, you can speak to, how do you make sure that your digital pill isn't, that information isn't going to go where it shouldn't go?
Yeah, so for us, we take security extremely seriously. And so what we actually do is we encrypt everything that you tell us at the level of your own phone. So, and it's this type of encryption that once any data gets sent up to us is irreversible. So the only way that somebody could ever know, oh, I said a certain thing about a certain contact is if they stole your phone or you lost your phone and they knew your password, similarly to if they could log into your bank account through your phone. So it's kind of the same level of security that you'd expect from all of the other pieces of data that you share with apps about yourself.
But do you get data back from the app, and what kind of data do you get, and what kind of information can you glean from that?
Yeah, so we do get data back. So the data that we get back is we can learn on a population level, you know, how frequently do people who are in recovery communicate with risky people? How frequently do they respond to behavioral nudges and decrease their own amount of risky communication? But we never know who the end users are that are having risky communication. We never know who the risky contacts themselves are. We also don't even know where the risky locations are. Even that's encrypted.
Right.
It's all at the level of your phone. So we can kind of glean these population things, which, you know, may sound with all this anonymity like it's not valuable. But when we went to one of the clinicians at Boston Medical Center we work with, when we finished our first pilot, we brought him this data and we said, did you know that 70% of your patients are willing to self-identify somebody as risky who was in like their top 10 contacts? He like fell off his chair. He's like, this is something we all know, but there's never been data to support it.
That's great. So how about you, Peter?
So we similarly encrypt everything that we have as well, but we essentially kind of anonymize the data too, so people are not assigned names that are tied to the pills. The pills are just, they're coded with just numbers. So, you know, if anyone got a hold of the data, they just have a series of numbers and times, but no linkage to patients, no linkage to drug type or dosing. So that's kind of how we get around I guess that's how we address security for opioids.
Okay. So then I think finally I want to talk about accessibility. I think, Sarah, you can speak to just even without this kind of technology, there's an accessibility issue about treatment for people who need help.
I mean, the statistics say that 90% of people in this country who need treatment don't get it.
90%?
90% don't have access to treatment. I mean, addiction in most parts of the country is not covered under your normal medical insurance. I mean, when you look at Mary Winnefeld, here's, you know, the wife of an admiral and, you know, one of the most powerful men in the US military, and she's on the computer trying to figure out how to help her son. If her son had cancer, a doctor would be beside her planning out her care. And of course, when you just go online and look at the millions of recovery places, it's really hard to know who's good. I mean, you pick up the phone and call, you start hearing prices of $30,000 a month, $60,000 a month, $40,000 a month. You ask them for what's their, their record of success. It's like self-reported, and you can't judge the statistics. And most of the treatment out there isn't based on evidence. It's mainly 12-step abstinence.
Do you know where is treatment available? In terms of the emergency room treatment and response, is
a handful of emergency rooms now, if you come in from an overdose, like at Mass General, will provide you Suboxone and try to connect you with a provider. But I've even been in, like in Cambridge, and places where I've heard women that worked at doctors' offices who prescribed Suboxone telling me, I always prided myself on calling back patients, and I have so many people calling up wanting a provider, and we cannot help them. There is a shortage of providers in this country, not just of medicines like Suboxone, but addiction doctors.
Are there some programs that is there legislation to try to get more providers?
Things are slowly changing, and changing for the better. And there is some initial funding. People are expanding Medicaid, and the government now is finally funding medicated-assisted treatment. So things are slowly changing, but the death rate is really, last year was the highest number of overdose deaths we've ever had. And where it's beginning to drop are the places, like in Massachusetts, just a tiny bit, that have embraced medicated-assisted treatment, that really have a more progressive view. You're beginning to see the numbers come down.
So, and how about for you guys in terms of accessibility? How can we address this with this kind of technology? It sounds intriguing. It sounds like it could be really helpful.
Yeah, so for us, that's why we put the app out for free. That's 90% of people who don't get treatment is exactly why. We know we're not going to cure addiction with this, but there just aren't enough free resources for people. So doing things like this, just kind of putting things out there that are available to people, I think. But yeah, it's pretty, I would say, it's pretty shocking. I've seen my own brother go and overdose, and they sent him home with a pamphlet that's like, here's this number you call. Can you imagine if someone did that to you after you had a heart attack? It's shocking. So I think really it's not even just the availability of resources, but the awareness. How do we tell more people that these things exist?
Yeah. How about you, Peter?
I guess from a clinical perspective, so I work in the emergency department, and at Brigham we also have a bridge program. So we, all of us as physicians are, the interesting part about Suboxone and methadone is when you look at the history of it in the United States, we've essentially called addiction a legal problem, not a medical problem. And I think that's part of the genesis of this issue is, as a physician, I can't prescribe methadone for opioid addiction. You have to go to a center, and you have to go through 8 hours of extra training to prescribe Suboxone. And then you can only be waivered to treat a certain amount of patients. And so there's all these kind of legal limits because addiction has always been a legal problem in our country. It's never been a medical problem. And as physicians, it's very hard to bridge that gap because although we want to offer treatment and we want to help, there are often no resources. There are no physicians to treat people. There are no recovery centers that are accepting patients at that time. So at the Brigham, we now, as of I think a few months ago, we now have a bridge program where we offer initiation of Suboxone in the emergency department, and they get linked to a clinician within 24 hours in our bridge program. So I think we're making strides. I think in terms of accessibility, it's important to know that medication-assisted treatment isn't the answer, and behavioral therapy is also not the answer. It's the combination of both that is the most important. And then I think the last thing is people come to us and say, well, I failed treatment because I relapsed. But, addiction is a disease, and part of the disease is to relapse. It's expected that's going to happen. And I think a lot of clinicians we haven't kind of wrapped our minds around that, you don't, people want to treat people with Suboxone and then never see them use again. But that's just not that's not possible, and it's not appropriate to treat people like that.
And the other thing I'll say too about technology, one thing that we've learned really a lot about this whole space is just how fragmented it is. So care is so siloed. Like social workers, case managers, recovery coaches, clinicians, none of them talk to each other. Where are the available beds? You know, like you're in the emergency room, you just got out of an overdose, you want to get treatment for like this 6-hour window when you're really motivated. If there's no bed available, you lose that. And that's something that we've really learned, is that it's really hard to mobilize these resources when they exist completely independent of each other, and using technology to kind of stitch some of that to get people that access right away, I think is also something that should really be focused on.
One other point, Sarah, maybe you could talk about the HIDA map.
Right. One thing I just like
Yeah.
to say, in
Yes.
Canada, you can pick up methadone at a pharmacy. You don't have to go to a clinic. You can pick it up at a pharmacy when it suits you, and if you miss your dose, they will deliver it to you. The same thing with Suboxone. We weren't able to, I didn't include it in, you know, the 30 minutes of clips, but there is a overdose map that is being developed for different parts of the country to track overdoses in real time as they are occurring. And the first time someone showed me the map, I was kind of astounded, because you'd get to the Baltimore area and it was just like red. I mean, so many overdoses. It was just like a sea of color.
And it's entered in by first responders,
Yeah,
the police
first
and
responders.
EMTs.
But what it does is, like for someone like Raul Gupta in West Virginia, is when he starts to see a lot of overdose deaths in Baltimore, he knows that a bad batch of drugs will soon be in West Virginia in about 8 hours, and they can mobilize emergency teams. So that's beginning to come online.
Yeah. I mean, then if you get a chance to check out the interactive that we did in Buffalo, they were making use of it's the high intensity drug trafficking areas map, which chronicles where these overdoses are happening in real time and indicates whether it was a fatal overdose or someone survived.
It's a sobering map, because you realize when you look at that, there are a huge number of overdoses happening every day in this country, across the country.
Okay. Well, this is really interesting. Thank you so much for this discussion. And if there are questions from the audience? Okay. Yes.